Hi, my name is Sunny Lee. I'm one of the neurosurgeons over at Highland Hospital. This is a neurocritical care update, and I'll go off my PowerPoint presentation that I prepared. We have some slides of the examples of traumatic brain injury. So today what I'm going to do is I'm going to focus on the theoretical aspect of the traumatic brain injury and the treatment, and whatever is relevant to our hospital and the practice guidelines relevant to this regarding this pathology. We'll go over that. And if you have any questions, though, you could always get in touch with us. So trauma is most likely the cause of cranial neurosurgical referral, and oftentimes with the severe traumatic brain injury, there are other systems that could be involved. So polytrauma is very possible, and when they come in with the anticoagulation, that increases the morbidity and mortality. So severe head injury guidelines, if you stick to that, it could decrease mortality by 50% and could save a lot of money in medical care and rehab costs. In terms of the medical aspect, one episode of hypotension could potentially double the mortality as well. So we have to make sure that we don't allow any hypotension.
And your definition of hypotension is?
Less than 90 of systolic blood pressure. And no prophylactic hyperventilation has been effective. I'm just trying to go over things that we think that it was valid in the past, but not anymore. Like mannitol can be given without monitoring if signs of herniations are present. Any extreme circumstances we could do this, but ideally you like to have ICP monitor to measure the pressure. Because oftentimes when you look at the clinical picture, it could be confusing. When they come in with the GCS maybe 8 or 9 and they become intubated, and all of a sudden your GCS is 3. And because of whatever reason, the medications or previous medication that patient had, your pupils could be dilated, so it could look very disastrous. But at the same time, you get a CAT scan, the CAT scan might not be reflecting those the clinical aspects. So you have to be careful with any kind of potential emergent intervention. ICP should be monitored in patients with GCS 8 or less. That's a recommendation, level 2. High-dose steroid, I think most people know that they are contraindicated in traumatic brain injury. It actually increases the mortality, and that's grade 1, the level 1 evidence. So I'm going to go over the Brain Trauma Foundation traumatic brain injury guidelines in 2016. This is the most recent guidelines that we have. I'm just going to go over our PowerPoint slides. Prophylactic hypothermia, that has not been proven to be effective. So we don't do prophylactic hypothermia anymore. Hyperosmolar therapies. Once again, ideally you like to have ICP monitor before you put that. Oftentimes we do it in the ER if in extreme circumstances, but usually we like to get a HES CT and get an ICP monitor prior to using mannitol. In terms of cerebrospinal fluid drainage, this is definitely relevant to our practice. An EVD system should be zeroed at the midbrain level with continuous drainage of CSF may be considered to lower ICP burden and most effectively than intermittent use. So this is actually case by case, and it can be little different for a specific situation. We don't always drain, and the ICP is normal, then we could continuously monitor. Use of CSF drainage to lower ICP in patient with initial GCS less than 6 during the first 12 hours after injury may be considered. That's a specific recommendation from this trauma guideline. In terms of the ventilation therapies, they don't recommend hyperventilation, prophylactic hyperventilation anymore, because CO2 is a very powerful vasodilator, and if you blow it out, you have a vasoconstriction, hence infarct could get worse. So if it's just to lower ICP, it has to be a temporizing measure. It shouldn't be continued. Okay, in terms of infection prophylaxis, early tracheostomy is recommended to reduce mechanical ventilation days, and the overall benefit is thought to outweigh the complication associated with such a procedure. But there's no evidence that early tracheostomy reduces mortality or the rate of nosocomial pneumonia. Another thing is the use of iodine oral care is not recommended to reduce ventilator-associated pneumonia and may cause an increased risk of acute respiratory distress syndrome. Yes,
and what is early when you're talking about tracheing them early? What is early for you?
Yeah, for us, it's within 2 weeks. In terms of DVT prophylaxis, low molecular weight heparin or low dose unfractionated heparin or Lovenox are used in combination with mechanical prophylaxis, but they could potentially increase the intracranial hemorrhage if there's an intracranial hemorrhage. However, we've been doing this for the last couple of years. We typically do it on hospital day 3 with either with heparin or Lovenox, and we haven't had increased intracranial hemorrhage. And we had benchmarked the San Francisco General trauma guidelines because they have more set protocols, and so we could discuss further going forward. Seizure prophylaxis, so there's a bold letter. At the present time, there's no sufficient evidence to recommend Keppra compared to phenytoin. Phenytoin, Dilantin could potentially lower the seizure risk within 7 days, only 7 days. So we only do it for 7 days, not beyond. Post-traumatic seizure is actually pretty well controlled, and the outcome, even though you had seizure within those 7 days, is not that bad. So this is something that we actually don't do right now. So this is something we can discuss. I think we use more Keppra than the phenytoin at this point, because you have to. There's potentially more complication with the Dilantin too, with the long-term use. But I think for short-term use, it definitely controls seizure better than other medications. So I had highlighted this: the management of severe TBI patients using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. What that means is basically saying that it's not just putting the ICP monitor, it's also you interpret the number and how you treat it. That's more important than just putting the ICP monitor. Because putting the ICP monitor, it can be diagnostic, but to do a therapy, you might need more interventions. In terms of the cerebral perfusion pressure monitoring, so this is I think debatable topic. Oftentimes I run into nursing staffs, and we do have records of cerebral perfusion pressure in ICP, and I told him not to go by the cerebral perfusion pressure. That caused a lot of confusion. So I'm going to explain to you why I don't go by cerebral perfusion pressure. But of course, cerebral perfusion pressure is probably more important than anything else, because that's organ perfusion pressure. But the tricky thing about that is nobody knows the optimal cerebral perfusion pressure. Besides that, lowering the pressure below 50 in cerebral perfusion pressure is not recommended. So in that guideline, management of severe traumatic brain injury patients using guidelines-based recommendation for CPP, cerebral perfusion pressure monitoring, is recommended to decrease 2-week mortality. Blood pressure thresholds, maintaining systolic blood pressure greater than 100 millimeter mercury for patient 50 to 69 years old may be considered to decrease mortality and improve outcome. This is what we do in the ICU. The upper end of the pressure is typically, when I started this job, we were using 140 as the upper end. And we had at least two occasions reported by Dr. Victorino that we had an adverse outcome with trying to control the blood pressure. It went too low and ended up having hypotensions. So we actually increased that to 160. So currently we're trying to maintain the systolic blood pressure 100 to 160. For intracranial pressure thresholds, treating ICP greater than 22 millimeter mercury is recommended because the values above this level are associated with increased mortality. So this is what we have been doing. And also it mentions that the rescue ICP trial, actually I have it on my PowerPoint. Rescue ICP trial looked at the craniectomy patient versus medical treatment, and they tend to have they tend to lower the mortality with the craniectomy, but they have more vegetative state patients, which makes intuitive sense because it's a life-saving procedure, but unfortunately in terms of the neurological function, they do not tend to help improve neurological function afterwards, and you could only prolong their initial state if you can. So going back to cerebral perfusion pressure, the recommended target CPP value for survival and favorable outcome is between 60 and 70 millimeter mercury. And I just highlighted the bottom part. Whether 60 or 70 millimeter mercury is the minimum optimal cerebral perfusion pressure threshold is unclear and may depend upon the autoregulatory status of the patient. This is a very good point, and I'll go over that a little more. Avoiding aggressive attempts to maintain cerebral perfusion pressure greater than 70 millimeter mercury with fluid and pressure may be considered because the risk of adult respiratory failure. So you want to avoid CPP greater than 70. So going back to cerebral perfusion pressure again, I think this is a main topic, and this is my kind of main topic in this presentation as to why do we recommend not going by CPP, because as I said, nobody knows for sure what the optimal cerebral perfusion pressure is. We know that lowering cerebral perfusion pressure less than 50 is probably not good, and also increasing that over 70 is also not great. So typically this guideline mentions 60 to 70. Most people use 50 and 70. And where that number came from, it's not entirely clear. But you could actually find out whether patients' autoregulation is disrupted. In most traumatic brain injury, your autoregulation is disrupted. So when your autoregulation is maintained, I just have a picture. So you have typically a sigmoid curve, and where there's a flat line which is within the range of autoregulation. So even though you have a change of cerebral perfusion pressure, because the autoregulation, either it could dilate or constrict the blood vessel to maintain the constant cerebral blood flow. If you're over the autoregulation period with the cerebral perfusion pressure, that could drive up the intracranial pressure with the high cerebral blood flow. If it's lower, then of course it's not good because you don't get enough perfusion. What happens when you have when you have a disruption in the autoregulation? You have pretty much a straight line, so you don't have the tight autoregulation period anymore. So anywhere could be either over or under. So how do we find out whether how do we confirm that patient's autoregulation is disrupted? So there is a paper that came from Europe. It was a joint study with Sweden and Scotland, that they basically divided two groups. One is the ICP-driven measures, and the other group is the CPP-driven measures. And they found out that when you have disruption in autoregulation, it's good to go by the ICP, and they have a better outcome. And when your autoregulation is actually maintained, then it's good to go with the cerebral perfusion pressure. So in this paper, it describes that, so I'll cut to the chase. So increase of 15 millimeter of mercury in the mean arterial pressure leads to increase in 2 millimeter mercury of the ICP. So that's kind of cutoff point. If it's beyond that, if you have more increase in the ICP greater than 2 millimeter of mercury, then you could say that the autoregulation has been disrupted. And if you have less than that, you could say the autoregulation is maintained. So I think this is what the San Francisco General does. We could definitely do benchmark this again to see whether to confirm patient's autoregulation has been disrupted, and you could kind of tailor the approach. So what is the treatment strategy? So oftentimes we get a call that, hey, ICP is greater than 25. We haven't stimulated him, but I just wanted to talk to you. Then the first thing that I say is that, has there been any change in medication, or has the patient had trip to the CT? Is everything patent? Is it zeroed correctly? So there are two main ICP measuring devices that we use in this facility. One of them is the intraventricular monitor with the also called EVD. The other one is a both intraparenchymal ICP monitor. The both ICP monitor has two different types, the fiber optic and strain gauge. Fiber optic is supposedly more accurate, but it could cause a microfracture over time, and it could drift over time. So you could have a variation of like 2 millimeter mercury on the same day, and it drifts over time slowly. So it could become eventually inaccurate. The good thing about the both ICP monitor is that the zeroing process is not as complicated as the EVD, and it could give you pretty accurate numbers. But the downside to it is you cannot drain the fluid, that it's not therapeutic. So a good thing about the EVD is that it doesn't drift over time. So you could say that it's reliable over time as long as they have a good ICP waveform. But you could drain the fluid, that you could lower the pressure if there's a problem. But intracranial, the both monitor cannot. You have to use other modality of treatment, mostly medications, to lower the pressure. So we have ICP waveforms. So you have basically 3 notches. The first one, P1, P2, P3. I wish I could show you the picture. The P1 is the arterial phase, and that's typically the highest of all. And the second one is the P2. That's a venous phase. That's the compliance phase. So whenever you have a swelling in the brain, this will go up high because you have less compliance. So you have a high P2, and P1 and P3 are lower than that. And when you have a hypotension and you have an arterial pressure problem, you could have a lower P1. And P3 is a dichrotic wave, which reflects the aortic valve closure. And sometimes you could have a dampened waveform, especially after craniactive. I think most ICU nurses are actually familiar with that. When you don't have a skull, you don't have the arterial pulsation anymore to bounce off from, so you have very dampened waveform when you have a EVD. So whenever you have a problem, the first thing you have to do when you have an EVD, ICP goes up high, then you have to make sure that it has been zeroed correctly. So we go by the tragus, or the external auditory canal, which approximates the foramen of Monroe. So that has to be the 0 point. I think people have different, the levels, but this is what we go by. So it has to be zeroed at the correct level. Second thing is that if you have trip to the CT or MRI scanner, you have to make sure everything is patent, because oftentimes we have to clamp it, because you could overdrain or underdrain because the setting is off during the transfer, so we have to clamp it. And when you come back, you have to make sure you clamp the, unclamp the, and make sure that everything's patent. And we just had a brief discussion with Ms. Heather. The exam changes, whenever there's a shift change, we recommend that both nurses, incoming and outgoing nurses, have the same session and confirm the exam. Because exam, the GCS, although it's a pretty reliable indicator, there could be some subjectivities involved. So we like to make sure that everybody has on the same phase for the exam. So whenever there's a shift change, we would have exams together. Okay, so I have a very busy slide here. So this is one slide that it is from my handbook of neurosurgery that most neurosurgery residents use in terms of how we deal with the intracranial pressure problem. So there's a first tier, second tier, And there's something that we always do, like head of bed 30 degree to 45 degree. And another thing is that we don't pay as much attention is the neck has to be a neutral position. So oftentimes when you have a cervical collar, so that's another reason to clear the cervical collar as soon as possible, because that could potentially affect the intracranial pressure too. And whenever they have a pillow, you have to make sure they're not hyperflexed. That could potentially occlude the jugular and increase the ICP. So those are the main things, and avoid arterial hypotension. Anybody who comes in with a trauma, we have to avoid hypotension. Hypotension is more damaging than the hypertension itself. Okay. And avoid hypoxia, of course. PaO2 less than 60 is not desirable. My recommendation usually is to keep it above 80 millimeter mercury. And the patient has to be kept normal capnic, meaning that PaCO2 has to be between 35 to 45. And ideally, we cannot get ABG very frequently, so we could go by end-tidal CO2. What we can do is we can obtain the baseline ABG and correlate with the end-tidal CO2, and we can monitor end-tidal CO2 and keep that keep the patient in normal capnic range. And the light sedation, of course, we don't typically like to do drip. I understand most patients would have some degree of pain when they come in, but we like to maintain the and we like to perform the neurological exam. And unfortunately, with the sedation, and that could affect the neurological exam. We typically like propofol because it wears off quickly. We use a fentanyl drip. We like to use IV instead of drips because I think, depending on the body habitus, fentanyl could linger in the body longer too. So unless there's a contraindication, we like to use as needed basis pain control than the drip. Okay, and there are specific measures like heavy sedation with increasing propofol, adding second agent, fentanyl or Versed, and draining CSF. Your body makes about 400 cc, 450 cc per day. So you won't hurt anybody just by draining 3 to 5 cc. So when you have a pressure problem and it's and before when we get called, we give you instruction. But the one thing you can do quickly is to make sure that everything is zeroed correctly, and you could drain 3 to 5 cc quickly to lower the pressure. That could be beneficial for the outcome. Hyperventilation, once again, we don't recommend doing hyperventilation for a long time because you could potentially worsen the infarct. Okay. Mannitol is probably most frequently used medication. Once again, we like to have ICP monitor before you use the mannitol because mannitol is a very strong diuretic, right? So it could potentially lower the pressure. In the setting of traumatic brain injury, when they come in, have an arterial line and there's signs of herniation, you give a mannitol, blood pressure drops down, you could potentially have cause worsening outcome of patient's recovery. And of course, that the mannitol can be used when that could potentially cause a kidney damage too. So you have to be careful and measure the serum osmol just to make sure it's below 320. And hypertonic serum, we don't use 23.4% here, but we do have 3%. So if you have any questions, let us know. We'll be available. And for the last 2 years, I appreciate your service, and I've enjoyed working with all of you. And I welcome all the inputs.